Hello, my name is Dr. Ravi. I'm a consultant neurosurgeon working with Zuleika Hospital, Sharjah. I have a background in both brain and spine surgeries, and I have a master's degree in advanced surgery from Sydney. What I'm going to do today is actually present a very simple topic to you. It's about a diagnosis which we see as a neurosurgeon, we see almost on a daily basis in our outpatient as well as in the ER. And I'm going to focus a little bit about how decision making is done in these cases. So decision making in neurosurgery is a very complex topic, but we're going to just narrow it down to one diagnosis, just to to open up an area where we can have a discussion on how medicine today needs to be individualized rather than going by what are the international recommendations and all that. So what I'm going to focus on in this talk is the fact that whenever we do a lot of radiological diagnosis, MRIs and CT scans today, this is done on a daily basis. I see at least 10 new MRIs every day. So it's so common to do these tests, but when we find something on the MRI or a CT scan, does that automatically translate to a lesion which needs surgery? That's something we're going to focus on. The discussion is going to be only on one diagnosis, that's traumatic epidural or extradural hematomas. These are real case scenarios that I've seen over the last few months in my OPD here. We're also going to look at why is this important? Why should we focus so much on decision making? I mean, if you have a hematoma, remove it, it should be that simple. But no, we are looking at major brain surgeries or spine surgeries where we have to look at the risk-benefit ratio for the patient. And in today's era, that's very, very important. We need to make sure that what we are doing for the patient has more benefit than risks involved. And I'm also going to focus on a bit of a small thing that I'm going to focus on international recommendations. I'm just going to show you a brief example of that and how international recommendations don't necessarily lead to decision making. I know people in the audience would probably think, what's so difficult about making a decision? Most diseases now have all these great recommendations coming in from thousands of patients' research, and you look at that and you decide whether a patient needs surgery or not. But that's not always true, especially in a given individual patient. So we're going to look at examples of that. Now, why is it important to make specific decisions in neurosurgery? We know this particular slide, medical errors and, fatalities due to medical negligence. These are topics that are discussed every day in popular media. And Dr. Atul Gawande, who is an Indian origin surgeon in the United States, he came up with this concept of timeout, which we are using in our day-to-day practice in the OR, which helps us, make sure that we've got the right patient, the right diagnosis, and the right surgery. So these were small steps that we took to, making sure that patient safety is paramount. But there's another reason why decision making is important. And I just want to focus on this little study that was published in 2015, where about over 500 responses were there to an online survey. And the same people who responded to the survey were neurosurgeons first, looking at if the diagnosis was being given to one of their patients. And secondly, the same person would respond to the survey as if he were a patient, if the diagnosis was made for him. And what they found were very interesting subjective parameters, which were very different on whether a doctor is recommending the treatment for a patient or whether it's for himself. For example, there were two conditions that I liked in this paper were vestibular schwannomas and AV malformations. Now, both these conditions, you can either have a surgery done for it or radiotherapy. Now, when many of these respondents looked at recommending the treatment for the patient, they said they would advise surgery. But if they were diagnosed with the same condition, they went for the more conservative approach and said they would prefer to have radiotherapy. Now that shows that there's such a lot of subjective bias in decision making. Another example in this survey was, neurosurgeons who had a very aggressive practice, the ones who operate on bad brain and spine tumors, they were generally more aggressive in managing gliomas or vestibular schwannomas or even trauma. The others were not so aggressive. And then there were neurosurgeons who were more experienced, like 10 years or more. Those were people who were less likely to recommend surgery for things like spinal pain. We know that spinal pain doesn't always respond very well to surgical interventions. So, experience, the kind of practice a particular surgeon has, whether he's recommending the treatment for himself, for somebody else, somebody known to him. There are so many factors which go into making a decision for a patient. So I'm going to look at three patients that I'm going to present to you. All three have the same diagnosis. The presentations were different and the treatment options were different, as well as the outcome. So the first one is a 8-month-old child who fell off his bed at his home. The child woke up, cried a little bit, had a few episodes of vomiting, and with pediatric concussions, a few episodes of vomiting are very, very common. We see this all the time, and it's not usually very alarming. But for some reason, the parents were very anxious. They got this child to the ER, and the pediatric ER specialist looked at the child and said, everything's fine. And, it's a minor bump. There were no external injuries. They said, we can wait and watch. And the father was very insistent for some reason. And we got a CT scan done, and there was this massive hematoma, and the child was perfectly fine neurologically. So I took this child up for an immediate surgery, and I'll show you that. But before we go to that, I just want to focus a little bit on this CT scan. You can see this massive hematoma here. But what's interesting is these hypodensities within the main clot. Now, there's a whole differential diagnosis of what this hypodensity could be, from anemia to CSF admixture with the clot and things like that. But in extradurals, we are always worried about a hyperacute clot with active bleeding. So when there's active bleeding happening, there are these little eddy currents which are formed in the hematoma, and those can give appearance as these hypodensities. So this child was taken up for surgery, but before that, I want to just mention to you that this is the international recommendation that most neurosurgeons will be following. It's a little old, but I don't think much has changed in the last decade or so. So an extradural hematoma with 30 mils of volume with any kind of Glasgow Coma score should require a surgery. And if it's less than 30, then you look at, how thick the hematoma is, how much is the midline shift, what is the Glasgow Coma score of the patient, and so on and so forth. And these criteria actually help in decision making. Now, in this particular patient, he fit the criteria of surgery, but anyway, he did undergo surgery. This is just a brief video to show you how massive the hematoma was. And you can see that that's a really massive hematoma. And this child was taken in for surgery instantly within 15 minutes, and we managed to get the whole hematoma out without any intraoperative consequences. The child did very well, recovered fine. This is the post-operative CT scan after 3 days, and he did very well. So this was a no-brainer. This is a large hematoma. You operate and get it out. I'll show you a similar but a different kind of a condition, also an extradural hematoma. This patient was actually a relative of our pediatric GP in the hospital, and he came to me after doing this MRI at another center. He was actually involved in a freak parking accident. So what happened is he had a little trouble with the rear camera of his car, and he had parked in his own apartment. The parking was on a slope, and he forgot to put the handbrake on. And the driver's side door was open. So while he was trying to make some adjustments, the car rolled back and he fell out of the car. And he got a minor bruise on his scalp. Nothing special, no loss of consciousness, no vomiting, nothing. 3 or 4 days later, he noticed some headache, which lasted for about 2 or 3 days. But then after that, he was fine and he was working all throughout. He didn't take any time off. He felt absolutely normal. But one of his friends suggested to him, he said, why don't you go just see a doctor, Uh, for some reason, you can't explain why people do that, but there's some fear in them which propels them to do things like that. And he went to see a doctor and he got an MRI done. And the MRI shows this really massive clot which is there on the left side. You can see on the temporoparietal region, posterior temporal going up to the parietal region there. And if you look at the blood clot characteristics, it falls into a subacute kind of a hematoma. But it was quite massive. And he had seen 3 other surgeons before coming to me, and everybody had advised him surgery just based on the clot. Not just the size of the clot, you can also see that there's definite mass effect on the brain. Now, I examined this patient and I found him to be perfectly fine. He didn't have any deficits. He did not have even the slightest bit of papilledema, no headaches, nothing. So I explained all the consequences to him. I told him it was unlikely to increase or cause any more problem than what it already had done, because it was already 2 weeks after the injury. And if you look at the recommendations, then definitely this hematoma should also have been operated. But I went with the conservative management. And this was the CT scan that we repeated 2 weeks after he presented to me. So a total of about a month after the head injury. And you can see that the clot has actually diminished in size by over 50%. Yeah. And it's really much smaller than what it was originally. Of course, it's a little hard to compare because this is a CT scan and the original scans were MRIs. But you can see generally the size is much, much smaller. The mass effect is still there a little bit because the ventricles are slightly smaller there. But it was decreasing in size and he had no symptoms. So we waited for another month. And so 6 weeks after presentation, we got another CT scan done. And this is 2 months after the head injury. And you can see that the hematoma has completely resolved. There's no mass effect. There's no evidence. If you look very closely to the CT scan, you can see a very thin hyperdense line here. And, just at the convexity there. And that was the only evidence that the hematoma was there. And he was fine and he's back to work and I haven't seen him since. So he did very well with conservative line of management. Now, this is a third case, also about an extradural hematoma. And this has a completely different presentation. Also a child, a 3-year-old child, fell down while playing. She was a very active child. She vomited a couple of times and then slept, but then woke up late in the night, early morning actually, and complained of severe headache. And she actually told her father, take me to the hospital, I'm having a lot of headache. Now this was quite strange for a 3-year-old child to do that. And they came to a pediatric ER at about 4 a.m. in the morning. And I saw the child. The child was running around the bed in the emergency room and she was perfectly fine. GCS 50, no deficits, no vomiting, she was fine. This was a CT scan that was done at that point. And you can see a small hematoma, not very large, but it's in the posterior fossa. And if you look at the density of the hematoma, the density is exactly like that of the cerebellum. So it's indicative of it being, again, a subacute hematoma. Not a chronic one, but it's quite subacute. Now, she had, on retrospective history, she had a similar injury, quite a nasty one, about 2 weeks ago. The father had not, she had just vomited once, but she was fine, so they never took her to the hospital, and she was okay after that. But what I see unusual in this case is there's a little streak of hyperdensity just below the transverse sinus there that's outlining the subacute hematoma. And if you just look at the last cut there, the hyperdensity is a little bit more. Now, the child looked fine. I wasn't sure. I said, this is too small a hematoma to actually go in for surgery. So let's see, and it's posterior fossa surgery. Posterior fossa extradurals are notorious for having oozing or bleeding from the transverse sinuses. And that would be an additional risk for this child. So we said, let's wait and we'll repeat a CT scan in about 8 hours. The child was admitted for observation in the ICU, pediatric ICU. And I went in for rounds at about 10:30 in the morning. And when I looked at the child, she was fine. She was, talking and everything, but she was a little dull. as compared to what I had seen her earlier. So we repeated the CT scan at 6 hours instead of the planned 8 hour. And you can see that the hematoma had actually completely changed in terms of not the size. Size isn't much bigger, but if you can look at the density of the hematoma, it's much more hyperdense. And if you can look at these images here, you can see that it's looking much brighter, much more white in color, and it's now skirting the transverse sinus. So a bit of it is going above the transverse sinus, and the mass effect of the hematoma was a little larger. These are the intraoperative images, and you can see that there's a little fracture there. And this was the intraoperative part. So there was an acute hematoma here during surgery. And this part, the liquidy part, was the more subacute part of the hematoma. So there was a acute hemorrhage over a subacute hemorrhage, and this was a transverse sinus, and there was a bit of oozing even from the transverse sinus during the surgery. And this was evacuated. It was a large quantity of hematoma evacuated, and she did very well with the surgery. Now, posterior fossa hematomas, definitely we need to have a very sharp vigil on these patients, and the threshold for recommending surgery is much smaller than supratentorial hematomas. That's because 85% of them are usually of venous origin, unlike the supratentorial hematomas where most of them are arterial origin. And the scope for a increase in the size is very minimal because of the restricted size of the posterior fossa. Mortality is pretty significant in these conditions of about 5%. Now, so this child did very well with surgery, but what I wanted to show you today was 3 diagnoses, all 3 of extradural hematomas. 2 of them fit the definite recommendations for surgery. 1 was operated, 1 managed conservatively, and the 3rd one was an acute on subacute hematoma. It did not fit the exact recommendations for her surgery, but she was nevertheless operated. So the whole purpose of having this presentation today is to bring to your notice that one size does not fit all when it comes to neurosurgery. We have to absolutely individualize and customize our approach to every patient. And this is a difficult art which is learned over years of clinical experience. This is just one example, but we see this all the time in degenerative spine conditions, in cases of brain tumors, all the time. So decision making is something that I would also encourage the younger generation of doctors to inculcate as rather than recommending the same kind of treatment or same approach to all patients. It has to be customized and individualized to the given patient. These are just my references, and I thank you so much for your attention.